So hello everyone. I'm just checking to see that everyone can hear me okay. Can you hear me all right, Lynn?
Yeah.
Yeah, you're very clear.
Fantastic. I think there may be a couple of people joining in the next couple of minutes. So I will just let everyone know that you should have come into this webinar on mute. We'd appreciate if you keep yourself on mute, and if you do have a question, then use the raise hand function at the top of your screen. We have built in some time at the end of the webinar for you to ask some questions, so it might be that you might want to keep a question until then. That might be a better time to ask it. The question might have already been asked. Let me just look to see if everyone's here. Right, I think we've got a few more people. Okay, I will start just so that we can keep good for time. Hello everyone, welcome to our first webinar. Thank you so much for coming. I'm Ellie, and myself and Lynn are trustees for Pectus Matters. And thank you for coming tonight for our first webinar with Aman Coonar. So we just wanted to, before Aman speaks, we just wanted to speak briefly about the charity, for those who don't know about us. So Pectus Matters is a charity that advocates for and supports patients in the UK with Pectus conditions. We formed Pectus Matters after a Pectus-focused event at the Royal College of Surgeons in February 2023. At the time, Pectus surgery had been decommissioned by NHS England, and so the purpose of that event was to share a united voice about the difficulties Pectus patients were experiencing without being able to access that treatment that had been accessible. For me, as someone whose life had been transformed by having Pectus surgery in 2018, I really wanted to impress upon people there that Pectus conditions aren't just cosmetic, but affect patients physiologically and psychologically. And it was at that event that Lynn shared the stories of 41 patients in the book Pectus and Me, which was just a fantastic resource that Len later went out to surgeons and clinicians. After that, we then did some work with the press and on regional television, just trying to get the word out about Pectus conditions and how they affect patients. So in May 2024, we became a registered charity, and we've built a small team that includes a number of skilled volunteers as well as our trustees. And now I will hand over to Lynn, who's going to tell you a little bit about what we do.
Yes, good evening, everyone. So I'm just going to spend a few minutes talking to you about what we're trying to achieve as a charity. So our mission, or indeed our purpose, is to ensure that every person living with a Pectus condition in the UK can access treatment and support. And we know that's not currently the case. And our vision for the charity, or our ambition, is to enable everyone living with a Pectus condition to live life to the fullest. So we have 4 strategic priorities. The first is to improve access to information and support. And we will do this by driving awareness for Pectus conditions and treatment pathways with associated organisations, so other affiliated charities, but also with different trusts and clinicians within the NHS. Over and above, our charity website is already providing, it's a great source of information, and we regularly deal with individuals who are contacting us either via email or via our different social media platforms. Our second strategic priority is to support world-leading research into the causes, diagnosis and treatment of Pectus conditions. One of the things we're currently doing, we do actually have a seat on the Restore trial, which many of you will be aware about. This is a a 2.5 million landmark trial that's seeking to establish evidence as to whether surgery for pectus excavatum does improve outcome for patients. And so we are advocating on that committee, feeding back thoughts and ideas around, how we ensure that the trial's doing the right thing for patients. Thirdly, we will advocate and influence on behalf of the pectus community with key stakeholders and decision makers. So another committee we sit on is the SCTS, that's the Society of Cardiothoracic Surgeons Pectus subcommittee, again in an advocacy capacity. So on that committee, we talk about, how can we try and take a non-surgical treatment more broadly across and make it more widely available across NHS England. And we go out to various conferences and represent the charity and you as patients. So we've recently presented at the British Thoracic Society annual conference in London. And Ellie and I have actually been invited week after next. We are meeting a number of clinicians at the Royal Alexandra Hospital in Brighton. And our aim there is to really convince them that pectus is far from just being a cosmetic condition. It really does have physiological and mental health impacts. And then finally, we absolutely underpinning all of this is to execute a robust and far-reaching fundraising strategy. Without money, we simply can't achieve our aims. And we'll look forward to talking to you about that at the end, because we really are hoping that many of you will be willing to maybe come and support us in some way. We also believe that working collaboratively with both patients, clinicians, managers within the NHS, this is the best way for us to affect change. It certainly works so far. And for that reason, I'm delighted to introduce now our guest for this evening, Mr. Aman Coonar, to our first charity webinar. Aman is consultant thoracic surgeon at Papworth Hospital in Cambridgeshire. He's also the president of the Cardiothoracic Society of Great Britain and Ireland, and he's been really pivotal in a lot of the progress that's been made to date. And Aman is going to talk you through his vision for the future for pectus care in NHS England. Aman, thank you.
So, hi, good evening, everybody. Thank you very much for that lovely introduction, and it's great to see you all. I'm going to go straight in with my presentation. Let me just share that with you. Give me a moment and we'll start sharing. I'll just put that onto the slideshow mode, and excuse me for a moment. There's always a moment of transition. Right, hopefully you should be able to see my presentation. Yep, you can see it. Okay, great.
That looks great.
No, that's lovely. So I'm also a practicing consultant surgeon, and in thoracic surgery, and I'm still on a 1 in 3 on call, and so I operate every third weekday and sometimes at the weekend. So it's a pretty busy kind of role. In order to talk about the future of pectus care, I need to tell you a little bit about myself, and also I realise that there'll be a very wide range of knowledge. And so I'm going to show a few pictures along the way, which you may have seen very similar before, just to try to get everybody onto the same page. And also, I did see out there that there are some friends that are known to me, and I'm really, grateful that they've joined today. Chris Satter is a consultant thoracic surgeon in England, and he is, really, really interested in this field. And also, very importantly, Ashley Johnston from Scotland is here. And I think the future of pectus care may actually be what is going on in Scotland. And so Ashley may well want to say some things as well. So, as I said, I work at Royal Papworth Hospital, which is a lovely place to work. Doesn't look like most hospitals. It's a dedicated heart and lung institute. And we used to do quite a lot of Pectus, actually. We used to have, at one point, we had the highest number of returns going into the Thoracic Surgery Blue Book, which is a 3-year record of the operations that were going on. But as you have heard, everything changed a few years back, just before COVID started. So let me go from that introduction about myself to telling you a little bit about Pectus. Now, I realise that many of you will know about this, but I think it's important that we actually oh, can nobody see the slides? It says, can everyone see the slides? Can you see the slides?
I can.
Okay, you can. Sorry, I was just seeing some messages. Okay, great. So the first thing to say is that thank you, everybody. I can see all these chats coming up. It's a very busy chat. It's coming up all over the screen. Okay,
well,
so
somebody else can't see the slides.
So the first thing is that not only are Pectus conditions is the shape of the chest not what other people have, but also there are other problems associated with them, and there's now good evidence that supports that. So with Pectus excavatum, which is the sunken in form of the chest, there is sometimes, and I stress sometimes, reduced exercise capacity because of cardiac compression, and that can actually be more or worse at different times and different activities. There can also be what we call a restrictive lung physiology, and what that means is that people literally can't get enough of a breath in, and that is on top of the psychological problems, which are completely understandable, and the social withdrawal that comes with that. And it's normal for young people and people of any age to have concerns about their appearance. It wouldn't be normal if people didn't. Our species would end very quickly. So all of this is normal, and these are reasonable things to feel concerned about and want to have fixed if possible. Carinatum is the form when the chest is sticking out more, and this can be associated with discomfort all the time, but also if one is leaning on it or lying on it, and also psychological problems and social withdrawal. And Pectus arcuatum can have a sort of mixed pattern, but including discomfort. And then there are other associated conditions which can include something called Marfan syndrome, and then spinal changes. We call that scoliosis or kyphoscoliosis, and then other rarer conditions. So there's a real range, and they can be mixed as well. So you'll have seen pictures of Pectus deformity where the breastbone and rib cage sink in and compress the heart. Now, this is the heart here, and this is the breastbone, and you can see the space between the breastbone and the spine gets very small. And believe it or not, you actually get worse cases than this. And this is, very sunken in. And actually, most of these slides, my friend Shyam Kolvakar has provided these, so I must credit him for those, because we worked together on a number of different presentations, and he has helped me with some of these slides. And this is a case where a single NUS bar has been put in to improve the appearance. And of course, there are variations on this operation. I'm not going to get into details about the operations, but this is the less invasive form of the operation. And then there's another operation which either involves a bigger scar, either down the middle or along the side, and that's called the modified Ravitch operation. Now, there are other ways of treating a sunken-in breastbone, and these include bells, which are suction bells, that if you apply them when the chest wall is still flexible, you can see a lot of improvement, and also braces, which actually push the breastbone and sometimes the bottom of the rib cage in, and these are similar to orthodontic appliances. And if you think about how much movement your teeth can get in childhood and in young teens, the same thing can be achieved with the chest wall. And we also know that it can happen in other parts of the body, because orthotics specialists, and Ashley Johnston works very closely with orthotics teams. They are very good at achieving correction of bony problems and cartilage problems. Then we spoke about carinatum, where the chest is stuck out. Yes, you can operate, and sometimes operation is the right thing to do, but at other times a brace can be very, very effective. And you can see over here, with time, you can get a very good result. You will have to, as with orthodontic treatment, carry on with maintenance therapy in some cases, in many cases actually. And then we spoke about arcuatum, which is a variation on this. Now, we talked about in order to talk about the future again, you need to look at what happened. And what happened was there was a very, very confused situation in the period before COVID. And the information out there was, on one hand, strongly supportive of treatment for patients with Pectus, but it was also very mixed, and there was also a lot of variation in outcomes. And it was probably the case that some patients who may have benefited from bell or braces were undergoing surgery, and then there were complications, and then there were other patients who needed surgery, and sometimes those operations didn't go well. So there was a lot of problems, and there was a decision made, and I wasn't involved in the decision. Very few people on this call were involved in those decisions, but if any. But the bottom line was Pectus surgery in NHS England came to a sudden standstill. And the additional problem with what is not a common condition is that the pathways for care for people with this were really not very well developed. So here and there you had some good pathways, but it was very, very inconsistent. And we were now in a sort of crisis situation, because there were people expecting operations on waiting lists who couldn't have operations, and there were doctors wanting to refer patients who didn't know who to refer them to. So in this sort of land of chaos, and it was actually quite acrimonious, and tensions were very high, we had to sort of take a view on how to solve this. And I've got an approach, a general approach, and that is that everything we do in healthcare has to be completely 100% about the patients. We've got to focus in on what the patients want and need. And then, as doctors and nurses and other people in healthcare who have developed some degree of expertise, we have to design, if possible, simple and clear pathways of care. And we have to support that with evidence. So if the evidence is not there or confusing, we doctors and other healthcare people have a responsibility on top of our work, on top of the 1 in 3 on call and all of that, to try to find that evidence. And we also have to find people out there who are willing to support us. It is an extremely noisy world out there. It is an extremely noisy healthcare landscape. Every single disease, every single professional group is competing for attention. So it doesn't actually do very much if one of us or a handful of us speak up. But when we speak together with our patients, our voice becomes stronger. So what we did, and at this point, my role was the chair of the Thoracic Surgery Committee for the Society for Cardiothoracic Surgery, is we started to gather in interested people, and we found allies. So through this process, I met Lynn and Ellie. I think it's really important that I actually talk about some of those allies, and we had a great ally in somebody called Fiona Marley, who has very recently, in the last 2 or 3 months, stepped back from her role. But she was Deputy Head of Specialised Commissioning for Highly Specialised Services for NHS England. And that's a long title, but basically what this means is that she tries to get support, funding and pathways for people with uncommon conditions. And she was just amazing, absolutely amazing. But also, I have to highlight Simon Kendall, who was a previous president of the Society for Cardiothoracic Surgery, who really pushed this forward and introduced me to some of the people on this call. And also Shyam Kolvakar, who is a very, very brave man and a very, very good surgeon, who actually set up and led our first Pectus Centre, which I'll tell you about more. And I have to also mention Ashley Johnston and her colleagues in Scotland for their brilliant work they're doing with non-surgical care. And we had a joint event. This is myself with the then president, Narain Murjani of the Society for Cardiothoracic Surgery, and Len and her book. And this was at the Royal College of Surgeons, and we gathered lots of people together. And literally about 8 weeks later, we were able to get this formally recommissioned. Of course, there was a lot of background work, but having that group of patients and families there was pivotal in raising our voice. Now, let me take you through what happened. Essentially, we got professional groups together and we had to designate somewhere to do the surgery. Now, the fact of the matter is, in England and in the United Kingdom, it is true, all roads lead to London. So we had to start this off in London, and we started it at Bart's. And just a few weeks, literally a couple of weeks after the policy statement came out, Bart started working. And literally at that stage, it was Fiona Marley, myself, Shyam Kolvakar, and a commissioning document. So it was extremely brave of Bart's to take that on and for Shyam to lead that. And we then went through a further formal commissioning process and brought in South Tees, and many of you will know Joel Dunning, who leads that service brilliantly, and also Alderhay, led by Ram, and that is for children. And so those have both started and are doing very well. So we've also sat down together, and you may have sat down and read this paper, or may not. You may have read the highlights of it, or you may have just heard about it. But we actually produced best practice guidelines. And the first author was Joel, who led it, and the senior author is myself, and the other people who contributed are listed there. And this clearly provided evidence which would inform the commissioning process and support the ongoing care for patients. Right, but that's complicated. And so what we had to do was we had to make a clear pathway, which we've done, and we are now following that nationally. Now, you've also heard about the RESTORE trial, which Lynn mentioned, and this will provide further evidence to support, we hope, the care for patients who have lesser degrees of pectus excavatum, because at the moment, surgery is only commissioned for those people who have the most severe forms of it and are likely to get the most benefit with an operation. Now, in addition to the pathway, there's now a clear referral process to the national MDT, and we have everybody gets a standardized set of investigations so that we know that when it comes to the decision making, and every Friday we have a team meeting with experts who've really grown their expertise, cardiologists, chest physicians, patient advocates, the doctors looking after the patients, and the surgeons will sit down and actually recommend people for surgery or other treatments or the trial or more investigations. So it's fair. Now, one of the things that you heard about was access to treatment. And so we are tracking where patients are being referred from, and it's really great. We're seeing referrals from around the whole country, and most of the thoracic surgery units in England have referred patients into the central service. And that's a scatter of the operated patients, which closely mirrors that scatter of where the referrals are coming from. We are doing really well in our weekly discussions. I'm sorry if not, there may be a bit of overlapping in that, but basically the number of weekly discussions are growing and a small number of rediscussions are taking place. And this is our surgical figures by quarters, and now We have done, you know, a considerable number of operations, and the operations are going well, and we're monitoring those outcomes. Now, what are the next steps? And this is where we're talking about the future of Pectus care. And I think there's a missing slide in here, because what I wanted to say, and this is really, really important, is that Pectus surgery is what was recommissioned. And Pectus surgery is a consequence of not getting needing Pectus surgery is a consequence of not getting treated when somebody is much younger with bells or braces or physiotherapy. And the reason Pectus surgery was focused on was because back in 2018 and 19, everybody was saying, we need Pectus surgery reinstated. If we were to look back on it, perhaps we would have done it in a different way. But to need to have a Pectus operation really means that conservative treatment has not been successful earlier on. And herein we have a problem, because even though surgery is more expensive and is much more difficult for the patient and has more risk, although the risks are now very small because it's being done in high volume centres which have got pathways, it's still riskier than a bell or a brace, which is also much cheaper. So it's really paradoxical that we've landed up in a situation nationally whereby we are doing operations which are really to catch up with this large group of people that were not treated in childhood. So Fiona and myself, and now Fiona's successor, who's recently started, we have been putting bids and are staking the argument, are making the argument that what we need to do is we need to move away from this concept of Pectus surgery towards Pectus care. And we've been pushing this for some time. We even wrote the guidelines as Pectus care guidelines. So we have the great advantage that in Scotland, which is a different but related healthcare system, they have already started and have been doing for some time with great success non-surgical care with bells, suction bells, and braces, compression braces for Pectus. And as a consequence of that, and Ashley can tell you more, perhaps 90% of patients who otherwise might have needed an operation a few years later are being treated non-surgically. So what do I see as the future of Pectus care? I see a pathway whereby it's easy for GPs to refer in, it's easy for patients and families to find out information about how to be referred in. I see a move towards bells and braces delivered by physiotherapists and orthotic specialists working with interested doctors, surgeons, pediatricians, respiratory doctors. It doesn't matter who they are, providing they have the expertise. And a smaller number of operations being done in a few centres. I don't know if it'll just stay the 3 we have now. It may be more, it may be less, but I see a safe and sustainable system going. And along with that, and that is in process through another mechanism, we're building a registry. So I would just like to say thank you very, very much for letting me tell you where we are now. I know we haven't reached the point whereby everybody can be referred in and have assessments and non-surgical treatment within a few weeks or months. We have a road to travel on, but I think that with your support and your voice, we will get there. Thank you.
Thank you very much, Aman. I really, really appreciate that. I will, if you could just stop sharing your screen, and I will share mine again. There.
You've got it back.
Fab. So we've made some time for some questions. There were a couple that were submitted beforehand that I will just read out for you, Aman, and then anyone who is attending tonight, if you want to ask a question, you're more than welcome to. So the first question we've had submitted is, if you could recommend 3 key habits or things that people living with Pectus should do daily to maintain or improve their overall health, what would they be?
Okay, well, so I'm not sure if this is over and above what I think we should all do. I mean, I think that we should all try to spend a bit of time every day outdoors. Not try to take our mind off life's worries, enjoy a bit of nature, undertake some exercise, and be nice to each other. I mean, I think those are the starting things, but those are general things. Going beyond that, I think that people with living with Pectus conditions, that's a very big question, because it also depends on where you are in your care. But the first thing is, I think you've got to stay really positive. Okay, so positive outlook is really important. Secondly, I think that whatever the nature of the problem you have, try to stay as fit as possible. And I think that there are a number of exercises which can be shown to you by a physiotherapist, but deep breathing exercises, keeping a good posture is really important, because sometimes there's a desire to try to hide the defect or the problem. I don't want to call it that, the problem as perceived by the patient, by posture. But I think it's really important to maintain a good posture and maintain good muscle strength, and then keep an eye, not every day perhaps, but regularly on the Pectus Matters websites for updates. So I think those are 3 good starters.
Fantastic. Another quite a question that we have that we personally get a lot as a charity is people across the UK are going to see their GP. This might be a parent or the patient themselves, and the GP is telling them that there's nothing that you can do for a Pectus condition, that it's cosmetic only. What advice would you offer to them?
Okay, well, so the first thing is that it's clearly not cosmetic only. Some cases may be primarily cosmetic, but it's not cosmetic only. So we want to inform GPs. We want to make them better informed so that they can make better decisions. I think that by looking at the Pectus Matters website, or the Society for Cardiothoracic Surgeons website, or the NHS England website, people will become aware that it's not just a cosmetic condition. I think there's a real challenge, though, for GPs, and that GPs have to know something about everything, and they can't, because healthcare is a very broad field. I think what a GP is, or a GP practices, is they know quite a bit about their particular patients. So I think that if you have found out more about the condition than your GP knows, then you yourself are becoming an expert in the condition. So inform the GP, and the GP is a bright person. They will go and explore it and have a look at it.
Okay, so we've had a question submitted by Ubi saying, my 16-year-old has Schurman's kyphosis. I think I'm pronouncing that right. We understand that the kyphosis needs to be corrected before any Pectus surgery. Would you say that this was correct?
So it's really, really difficult for me to comment on any one individual case without the proper information. So the question is very yes or no, I'm afraid. And I think that what's important in healthcare is to know that there are different ways of doing things. And what is important here is that whoever is looking after the Sherman's condition, and whichever is the Pectus centre that you've been referred to, is that they discuss with each other and correspond. So often one condition, well, usually one condition will be done first before the other, because it's very important not to make the other condition worse or cause difficulties in treating the other condition if you don't get the order right. So that is about communication between professionals.
Yeah.
So I'm sorry I can't give you a yes or no.
Well, but you don't have a patient in front of you, do you? And everyone's so unique. I know, for example, I have 4 curves in my spine, one of which was a kyphosis. And after I had my Pectus surgery, we expected there to be a big change in my spine, but there actually wasn't a change at all. Whereas I know others who have had a change in their spine after Pectus surgery. So I think it is very much individual for each patient. Caroline has her hand up to ask a question. Do you want to go, Caroline?
Hello, Caroline.
Hi there. Hi.
Hi.
First of all, I want to say...
If you want to put your camera on, please do.
Okay. Bear with. First of all, thank you so much for such a brilliant talk. It's been really, really helpful. So just a couple of questions. My son is 13 and we have been back to the doctors a few times in his life with complaints of chest pains, but have basically been signed off as other things. And last November we went to our GP and he said, like you've just said, that they say it's all cosmetic and he's just going to have to live with it. And he is so self-conscious. He's also autistic and he just hates the way he looks. So his self-esteem is on the floor.
I totally get it.
We have been referred to the Royal Alexandra Hospital in Brighton. We were referred back in December and still haven't got an appointment. Now this appointment's to see a paediatric surgeon. I wondered if that's like the correct person to be seeing. And also my other question was to us, we think his Pectus is quite severe looking at other pictures of people. And I just wondered, how severe, if your test can be too severe to have the bell, and also when you said to kind of start early and intervene before you need an operation, how young is to kind of start these processes early?
Sorry, when you say, do you mean
as in his age? So he's 13. Is he should he have started with the bell a lot earlier, or?
Well, so as it happens, I think the next person who's got their hand up is actually Ashley Johnston, who's probably got the biggest experience of this, or one of the biggest in the United Kingdom. So it might be worthwhile actually passing that question over to Ashley. I mean, because I'd give you my view, but she might have a slightly different view as to when to start that. The other question is, can things be too severe for the bell? Is that what you said?
Yes.
Yeah. So I think you can have very, very severe cases, in which case you wouldn't want to use a bell. But I think the majority of cases do have some response to the bell. But I'll go back to your first question, which is that you've been referred to Brighton, to the paediatric department there. Yes. So I happen to know that there is at least one, if not more, paediatric surgeon based in Brighton who has a particular interest in this.
Well, let's hope we get them then.
Well, so no. I mean, but probably the cases will go through to him. Right. So what I would suggest, if you believe you've been referred there and you haven't heard anything, is I would suggest to you that you contact...
on the waiting list. I rang them, but it's just apparently quite a long waiting list. So she said it's just, we will hear, but they don't know when. So I'm just hopeful that that's the case.
Well, I would encourage you to follow it up again.
Okay.
Okay, yeah. So I'll just say something that, I'm not asking you to, and I'm not even suggesting that you're doing this. Doctors don't mind being reminded about a case. okay? Because we get referrals every single day, and everybody's prioritized based on a little bit of information, and that they go into order, but sometimes that needs to be changed. And if your child is having pains, then I think that is a reason that you should highlight that.
Okay. Yes. Thank you.
Okay.
Yeah, thank you.
Caroline, just to say, my eldest has got Pectus excavatum. He was treated far too late. The vacuum bell didn't work. Do not take no for an answer. I think you've still got a chance at 13.
Okay. Right.
If you go onto the Pectus Matters website, or onto the the SCTS website, we'll send all the links out after. Take a copy of the pathway and say that you need to get referred, and pick up with us offline, email us at the charity and we'll give you more support.
Thank you so much. That's really, really great. Thank you all. Thank you.
I don't know if Anna Taylor wants to go next, who has their hand up.
Hello, thank you. I'll put my camera on as well so you can put a face to the name. Firstly, thank
Hello.
you. This has been super useful, and our first kind of experience of listening to, people talking about Pectus. So our 7-year-old daughter has got Pectus excavatum, but also has Louis Dietz. So this has been really interesting to listen to, because we've kind of done our background reading and read that the suction is not suitable for patients with Louis Dietz. So that was kind of my first question, as to clarifying that and just the rationale as to why. We don't actually live too far away from Papworth. We're in West Suffolk. But our daughter's under the care at Great Ormond Street Hospital because systemically she's quite affected by the Louis Dietz. So it was just to kind of get an understanding of, we feel, and again, comparing to other photographs and presentations of Pectus, that it's quite severe. She has cardiac conditions, she has lung conditions, but each clinician we see and question about Pectus kind of push it to one side. No, you don't need to worry about that. No, it's not affecting anything. And we just wondered if it would be worth, at her young age, to have a review by somebody like yourself.
Gosh, I wish I could answer your question better than I'm going to. I mean, Louis Dietz is a rare syndrome, very rare. And you must be going to a national referral centre to Great Ormond Street. I don't know how many centres are actually looking after that. I can honestly tell you I don't have the expertise to answer your question. As an adult thoracic surgeon, what I would do is I would speak to children's specialists, including the people who look after Louis Dietz, and Ashley, is that you there? Yeah, Ashley. Why don't we ask Ashley?
Thank you.
Yeah, Ashley, are you able to comment on either of these two important questions?
Yeah, I'll come in on the current question just now. I don't have any experience either in this, although we have got, in Scotland, we've treated over 300 children with vacuum bell now. And my advice would be that the clinician that would be looking to implement the vacuum bell would need to work with your child's consultant that monitors the Louis Dietz to do this with some element of caution if they felt it was appropriate at all. So yeah, I can't particularly answer that either. We have used vacuum bells with connective tissue disorders, but again, just done it in liaison with their paediatricians and used it with caution as well. I maybe wouldn't be completely ruling it out. I think there's probably a discussion there to be had.
Thank you.
Is that helpful? I don't know if it is helpful.
Yeah, it's tricky because we have a local paediatrician at our local district hospital, but the majority of our daughter's care is at Great Ormond Street. Cardiologists, orthopedics, gosh, there's a list. But I think regarding this particular clinical presentation, nobody really wants to kind of have that conversation about it. She has regular MRI, cardiac scans, which kind of shows, you know, the pectus. But it's just, we just want to do the best for her. And yes, it's very rare. So we're learning as we go with it. And it's just who's best to help.
Sorry,
sorry, Aman.
Can I just make one suggestion? I would. You've got a local paediatrician, and you've got specialists at Great Ormond Street, and you'll know how the relationship and where the expertise lies. I would suggest that what you do is you ask either of them, and I imagine because of all the specialist workup, probably Great Ormond Street, to actually liaise with the National Pectus MDT and ask for your child's case to be reviewed, because inputting into that, we also have a paediatric surgeon, and the designated national centre for paediatric pectus surgery is in Liverpool. Now, I'm not saying surgery is the right solution at all here, but what I'm saying is that you have got some expertise there that may provide some guidance.
I know that I don't have a clinical background, but Anna, I do have Marfan syndrome, and so I have spoken to a lot of patients who have a pectus condition and also have Marfan syndrome. I know that people with Marfan's are using the vacuum bell, albeit with caution and like under supervision from a cardiologist. So I don't see why, if patients with Marfan's are doing it, then patients with Louis Dietz would also do it. I think it would just, like Aman and Ashley have said, be about communicating with the consultants and the clinicians.
Yeah, and I think that's it, isn't it? I think when you've got so many multidisciplinary teams involved in individuals' care, it's trying to connect it. And I think probably the cardiologist at Gosh, she oversees the Louis Dietz and connects us with lots of other people. So we'll reach out to her and ask her to do a referral. Thank you very, very much. That was super useful. Thank you.
That's no problem.
Good luck.
Thank you.
Can I come back in? Sorry, can I just come back in as well?
Yeah.
Yeah, it was just to say about, I think it was Caroline, you were just asking about your son's age and severity as well for vacuum bell, and it was just to say that age 13 is a perfect age for the vacuum bell, so don't be worried that he's too old. 13 would be quite appropriate, but severity, there is an issue with severity. So if the pectus excavata becomes very severe, it's quite difficult for the vacuum bell to pull the chest forward. However, that's not to say that it shouldn't be the first line, because there could still be some improvement from it. So absolutely, I would encourage you to explore these options.
Thank you so much. Can I just also ask, it's just come to my head, you're talking about other syndromes. Ashley, my son, is hypermobile, and I have concerns that he may have Ehlers-Danlos syndrome, which I know is linked to pectus. Would he still be able to have the bell if he's not been tested for it or anything, but would there be problems for him to have corrective help with the pectus with that syndrome?
No. He could still access services. I think if it was vacuum bell again, it would just be with caution.
Okay, great. Thank you so much. Thank you.
Can I just mention one thing? I think it's important that I just remind people that unfortunately in NHS England, we don't currently have the bells and braces commissioned, whereas which means the NHS covers it completely. At the moment, that's only available in Scotland. So the assessment of patients is covered. That's the surgery for severe cases of pectus excavatum is covered. But we are working hard, and unfortunately, I wish I could give you a timescale, but I can't. We're working hard to get non-surgical treatments available.
And that's a huge priority for us as a charity as well, because I think that we understand that it's our understanding from the interactions we've had with patients that early intervention with non-surgical treatment stops patients from having to have surgery. Which I know if I didn't have to have the surgery and I could have worn a vacuum bell when I was younger, I would have much rather had that And yes, Lynn has just put in the chat that we do only know of one place in the country, in England, on NHS England, that offers the vacuum bell on the NHS, and that is James Cook University Hospital in Middlesbrough, and they are happy to take referrals from people across England, but that is only the only place currently doing the vacuum bell on the NHS in England. Unfortunately, I think we're going to have to stop because we've run out of time a bit, but I would encourage anyone to please do send us, oh, I've stopped sharing my screen. I would encourage anyone to send us an email and ask us questions that you haven't had answers to. We're really, really thankful for you attending tonight. And there's lots of ways that you can help support us as a charity in order to try and get our priorities met and get a lot of this care back on the NHS. So you can become a friend of Pectus Matters, our website. You can volunteer your time to help us. You can fundraise. So we recently have had a couple of people who've walked up Mount Snowdon and done a fundraiser for us. And you can tell people about us, and that's not just for patients or parents, that's for clinicians. We would love it if you would tell your patients about us so that they can come and get support from us, any additional support from us. Patients and parents, please tell your GPs about us if you're struggling. Print off the documents that we have on our website that you can take to your GP if you are struggling. And yes, do email us or message us on Facebook if you have any questions. I will be sending out the recording afterwards, but mainly just wanted to say a massive thank you to Aman for your time and for your expertise. You've been so incredibly helpful and charitable to our charity, and we're so incredibly thankful that you've been able to come tonight.
Well, no, thank you very much for having me. This is something that's very dear to me, and I believe that not only can we, by working together, can we help people with Pectus conditions, but we can also do this for many other medical problems. And so thank you for inviting me, and also very grateful as always to Ashley, who has this brilliant service in Scotland, and we're trying to follow in her footsteps in England.
Fantastic. So again, Aman, thank you so much from Lynn and myself and all the trustees and volunteers at Pectus Matters. And yeah, we hope you all have a good evening, and thank you very much.
Thank you, Ellie.